So, thank you. That's really interesting discussion. The oral azacitidine brings us actually into some updates that will be heard at ASH. And I'll focus just on a few trials that are being presented here in New Orleans on the use of azacitidine and lenalidomide in MDS and in acute myeloid leukemia. So you heard from Ruben the oral azacitidine is being developed. There is a current study of oral azacitidine in patients with RAEB1 and RAEB2, so that's patients with 5 to 20% blasts. In the study, 23 patients were accrued. They received azacitidine orally, 300 milligrams daily for either 14 or 21 days. And the complete remission rate was 22%. The overall response rate was 50%, which reminds me a lot of what I might expect in a higher risk group of patients getting sub-Q or intravenous azacitidine. So the benefit really may be the toxicity profile, the schedule and the convenience of the oral regimen. In terms of toxicity, you still see some of the same toxicities, and there were a couple of patients in that study who had grade 3 or 4 diarrhea or nausea, vomiting, and I think that's something that was seen in the phase 1 experience with that as well. Is that correct, Ruben, the GI toxicity?
It certainly is, and I think to some degree, as Mark was raising, I think the studies we've had up to this point are trying to emulate exactly the same sort of intensity of therapy that has been the traditional norm. So I think it's not a little too unexpected that the toxicity should be similar. You know, I think that presents some of the opportunity. Once we're comfortable that it's at least kind of equivalent, you know, then we explore, you know, ways to manipulate efficacy and safety.
Well, in that study of those 23 patients, the rate of marrow CR was 67%. Now, for an older patient just getting treated for their myelodysplastic syndrome, I don't put much stock in marrow CR, because that basically means you've reduced the blast count, but their counts haven't recovered. So patients don't like that, okay? They're still sick. But if your goal is to move them to transplant, that might be all you need to do. And in fact, a couple of patients in that study did move on to allogeneic transplant. The French have taken an interesting approach of the use of lenalidomide in their patients with deletion 5q with other cytogenetic changes. So you may remember there was a paper published by Lenalidomide where they did a phase 2 study of just single agent lenalidomide in intermediate to and high risk patients with MDS who had deletion 5q. And they saw responses, but it was only in the patients who had isolated deletion 5q, a preserved platelet count. So what they've done there in France is they're doing a study of combination of lenalidomide with either intensive chemotherapy, daunorubicin and cytarabine, for patients fit for chemo who had RAEB2 or acute myeloid leukemia. And then patients not fit for chemotherapy would go on a different study where they would receive azacitidine for 5 days and then lenalidomide. It was a phase 1, phase 2 study, so they had 2 different doses of lenalidomide, 5 or 10 for either 14 or 21 days. Now, in the patients who got intensive therapy, they were very happy with their results. This was a group of patients that had high-risk features. For example, 80% of them had complex karyotypes with deletion 5q. But they were very surprised to see an overall response rate of 61% and 46% were complete remissions, and most of those CRs were cytogenetic responses too. And they only saw 5 early deaths, which is quite remarkable in an older group of patients, 5 out of 82. With the higher dose of lenalidomide, a little bit more hepatic toxicity. So that, I believe, they're moving forward. What they were less enthusiastic about was the other phase 1-2 study of AZA with lenalidomide in the unfit patients. 35 patients here who got AZA for 5 days and then the lenalidomide, and 43% had to discontinue because of progression or death before they could get cycle 2. And the overall response rate was only 16%. So clearly more work needs to be done there. And then finally, our friends from MD Anderson have presented a phase 2 study of the combination of azacitidine and lenalidomide. Now, Mikhail Sekaris has published a phase 1 and then a phase 2 study of AZA for 5 days with 21 days of lenalidomide, 10 milligrams a day in higher risk MDS patients, and that's one of the arms in the current SWOG intergroup trial. MD Anderson you did your own phase 1 work in this population and found that the most ideal combination of AZA and lenalidomide would be 5 days of AZA and followed sequentially by 5 days of lenalidomide, right? 25 milligrams a day.
Correct.
And in that study, they saw a CR rate of 22% and CRP rate of 12%. So not much different, I think, from what I might expect for azacitidine alone, but worthy of further study.
Well, where we're going further, we have a study combination of histone deacetylase inhibitors plus hypomethylating agents. One of these agents is plasinostat being combined in a randomized fashion. It's a phase 2, 5-azacitidine plus or minus plasinostat. And if it's positive, we get a sense within 100 patients is to move to randomized frontline trial.
I think you nicely summarized the data with the combinations. There are so many questions to ask, whether it's better to do them as a combination strategy versus sequential therapy. But those are the studies that are going to answer the question. Again, I think all of us in the field hope that the intergroup study will be a positive study to set a new standard of therapy, either lenalidomide or vorinostat combination arm. And in the AML, I think SWAG did a study with single agent lenalidomide in deletion 5q. There was not much signal alone. So now this brings the question in combination with chemotherapy. And again, there will be questions about concomitant therapy, sequential therapy. But those are the studies to answer those questions.
Okay. Well, thanks. That's been a great discussion on myelodysplastic syndrome, where it stands and where we hope to go. Let's move on now to